Hi, we're going to be going over the thoracic spine today. We're just continuing on down the spinal column, so I'm just going to move on forward. All of these PowerPoints are going to start pretty much the same when we're covering the C-spine, T-spine, and L-spine, so really same material on there. Just make sure you take a good look at it. It might make a little bit more sense as we get a little bit further down the spine. Thoracic curve is classified basically as a convex curve. It's going to be the first primary curve. So if you remember these or have a hard time remembering them, just remember this goes cervical. This is going to be compensatory, primary, compensatory 2, primary 2. So it's going to be CP, CP basically. So you should be able to figure out if it's compensatory or primary curve if you can just remember that little device. Thoracic spine, you basically have 12 vertebrae that make up the mid-back. T5 through T8 are considered the typical thoracic vertebra. That means as we get more towards this area in here, these are more commonly what your average thoracic vertebra should look like. T1 through T4 share some similarities with the cervical spine, so they're not considered to be the classic thoracic vertebra. And then T9 through T12 are considered to have some similarities to the lumbar spine. So just realize that it's going to transition above and below based on the spines at both ends. Spinous processes travel a little bit more inferior than the cervical vertebra. So if you look at them, they're going to start to dive down a little bit more before we get into the lumbar vertebra. We'll start to kind of stick out again a little bit. Most of the anatomy is pretty much the same. There are some key differences though. On the thoracic spine you have these facets or demifacets, which are basically these little smoothed out areas for the articulations for the ribs to attach. They are common to all 12 thoracic vertebrae because they do have basically 12 pairs of ribs, so you're going to have these little facets or smoothed out areas on each one of these thoracic vertebrae. Just shows a little bit where those little smooth facets are. They're going to be on the vertebral bodies, but you also have one on the transverse process as well, because the rib comes around or hits the transverse process before it articulates into the vertebral body. So on both sides here, you're going to have the ribs kind of coming around. So it shows graphically here in the colors where those facets kind of line up to. You'll notice that the vertebral arch is pretty much the same. The anterior portion of that arch is created by the pedicles and go into the transverse processes, which go a little bit more posterior. You're going to have the lamina on each side, and then you're going to have a spinous process making up the back portion posteriorly. Cervical spine, just look for that for the basics. You have either a full facet or two partial facets on each side of the body. Those partial facets are called demifacets. These facets join to form the costovertebral joint, which is where the head of the rib articulates. So as the rib comes around, and we'll have some other slides for this that'll show it a little bit better, they do connect at those 2 points. If you look down here, rib 1 only articulates with T1, so it has a full and a demifacet. That means rib 1 articulates only with thoracic spine number 1. It has a demifacet because once we get down to 2 through 8, they actually connect in between two vertebrae. So the rib facet is going to actually touch two of these vertebrae, kind of overlaying the intervertebral disc space a little bit. T10 through T12 have whole facets only. Those ribs do not connect with two pairs. They only connect with one specific rib. T9 has a demifacet superiorly only because once we get to 10, 11, 12, those connect directly. Psychopopliteal joints of the thoracic spine are seen at about a 70 to 75 degree angle from the mid-sagittal plane. So what that means is the patient is going to be LPO or RPO. They're going to angle down probably about 20 degrees, 15 to 20 degrees. It's not much at all. This is so that we can see the zygapophyseal joints. Now, if you think back to the cervical spine that we had, we saw our zygapophyseal joints on our lateral view. But on our thoracic view, those are only seen on the oblique view. So it changes it around a little bit. Thoracic intervertebral foramina are seen only on the lateral view, so that is also backwards from the cervical spine as well. The little kind of IVF that we looked at on the obliques of the C-spine are now going to be seen only on the laterals as they go down. And this isn't a great example of a lateral, but you will be able to see those spaces as you look at lateral images. Dressing instructions, pretty much everything from the waist up is removed. No necklaces or other jewelry allowed, because that'll hang over T3, T4 typically. Beware of iron-on artifacts on t-shirts or sweaters, especially the little embroidery with the little polo players or alligators. Those are going to show up occasionally if they're close to the center line. No bras. Bras have to come off on this. Shielding. All patients should be shielded for this exam on the AP and lateral views. And additionally, a shield can be put on the table next to the patient to keep some of the scatter from reaching the IR. I don't know if this page is accurate. I'll have to double check that. But basically, as the patient is lying on their side, you have a shield behind them posteriorly, so that can kind of clean up a little bit of the scatter that's generated because of the heavy thickness of the part being so far away from the, I would say, bucky. So it's generating quite a bit of scatter on that, and that lead just picks up some of that scatter. Breathing technique. We haven't talked about too many breathing techniques, but a breathing technique can be used to blur out the lung markings, making it easier to visualize the thoracic vertebra. If you look here, you do not see the lung markings that you normally see across here. The vertebrae look pretty square and easy to see the edges all the way throughout. You can see the lung markings, which are partially blurred out here, but that is not blurring out the vertebrae, which are staying in the same place. You need at least a 2-second exposure or the corresponding reduction in the MA setting. Should be enough to obtain the ideal images on that. Patient must hold very still to avoid motion repeats. So what the patient's going to be doing is just holding very still and then just slowly breathing in and out so that we can blur this out and get a nice clean image of that. Any structure that sits within the lung field, typically we are going to have some type of breathing technique. Positions we're going to go over: AP and lateral, alternates or swimmer's views, which we covered in the last C-spine PowerPoint. The LPO and RPO for the zygapophyseal joint spaces aren't really done all that often. You may do that occasionally, but it's very rare that we have that as part of the regular series. Flexion extension views, we also do those occasionally for the T-spine. AP view is going to be done at 40 inches. You can increase the distance a little bit if you have a very tall patient. Use a table bucky with a small focal spot. This is going to be a 14 by 17 lengthwise. The spine is longer this way than it is side to side, so you want to put the 17 inches going all the way down here. Perpendicular tubes, and no tube angle on this. CR should be about T7, which is about 3 to 4 inches below the jugular notch. The jugular notch in this area, 3 to 4 inches down, should be the centering point right through here. Collimate side to side. This could be collimated better. If you suspect that they have scoliosis, you can leave it open like this, but typically you want to trim this in side to side as much as possible, so you get a nice clean image. You get all the radiation basically hitting the spine, and it'll look a little bit more black and white rather than grayed out. Shield must be on the lap. Anode to heel effect can be minimized by placing the abdomen under the more intense side, which is the cathode. So if they have a kind of a narrow chest at the top and a big old belly kind of down towards the inferior side, then that can kind of wash out these vertebrae up here. So you want to kind of even that out a little bit if you need to. Marker should be near T3. Since we are going to do a left lateral, you should use your left marker. Should be in this area. T1 does have a rather large transverse process here, so you want to get below that just a little bit by putting it not at the top of your image, but just down a couple inches here. If you put it down low like it is down here, there is a chance if the patient is not perfectly straight down the middle of the table, the vertebrae are going to get a little bit wider and your marker could be in that area. So keep your markers up high, but not all the way at the top. Lateral view, also 40 inches, same thing going down here. We are going to use a breathing technique for this. Perpendicular tube angle, CR the same but more posterior. Because we want to get the entire chest on there, you can use your chest centering, so you can find the vertebra prominens, go down 7 inches, and find the midpoint of the back on there as well. Shield across the lap, another shield behind to pick off scatter from reaching the IR like we talked about. All you're going to do is you're going to put a separate shield going down here, just along the back, just to kind of clean up some of the scatter from that. Check your hips, shoulders for rotation, so check up high, make sure they're straight. Check down by their lower lumbar area, also to make sure that they are straight at the bottom. You can use a sponge to keep the lower T-spine from sagging. I don't see that used that often though, but you can put it under the hips to keep your spine from sagging down and then coming back up. Swimmer's view, as covered before, you just want to make sure that you can see whatever vertebra at the superior border, either T1, T2, maybe sometimes T3, if you have a very thick person towards the shoulder area. Down here, you can use an angle of 13 degrees cephalad. Opens up some of the disc spaces a little bit better in this area. There's a variety of ways to do that. Some techs like to use a breathing technique for this issue. Also, some like to shoot a straight T-spine with no breathing technique on it as well, which works just fine. Just consult with your techs and your CIs about what works for them. Landmarks, C7 vertebra prominence is about the same level as the body of T1. Jugular notch, right up in here, right between the clavicles. Sternal angle is about 2 inches inferior to the jugular notch. That's a little harder to find, but basically it's where the sternum starts to go a little bit more inferior. Xiphoid process correlates to about the level of T10, T11, so if you want to check that to make sure that's on there. At the bottom of your image, it should be low enough that you still get 11 and 12 on there. Again, I think this page is outdated here, so we'll double check that. To show some of the pathology, most of the kyphosis you will see from patients kind of bending over a little bit more are from wedge fractures going down. So this is your normal T-spine. What happens is that patients will start to lose height when they get these types of fractures in their thoracic spine. And these are the different grades on here. Typically they're going to be wedge fractures, but they can get biconcave and crush fractures too. Problems associated with the disc. This is everything that can go wrong basically in the spine. Degenerating disc, wearing away due to excessive use of age. You can read through these, look at these normal discs, how they kind of protrude backwards. These herniated discs are big problems because they bulge against the spinal cord. Some more pathologies. This just shows you the mechanical issues that go on with compression fractures. If one starts to go, not uncommon to see this wedge-like appearance on here. Some pathology. You can see a wedge fracture right through here. Pretty significant. Typically the other vertebrae will be alright because one vertebra will take a little bit more of the damage than the one above it or below it. But occasionally you get something like this that has 3 compression fractures right through here. I'll let you read this on your own. Some more anatomy practice that you can look at. And that basically concludes this slide presentation. I will say that on the obliques, going back to that, is that the zygapophyseal joint spaces on the upside are the ones that are the area of interest. I know we've covered some of this in the C-spine, and it's basically the same concept with the area of interest when we're talking about the obliques. The obliques are going to be the upside. So if you're doing an LPO or RPO, C-spine or T-spine, the area is going to be away from the bucky. Hopefully we'll fill in some more of these gaps in class. The T-spine, not ordered as often as the C-spine and lumbar spine, but still generally pretty important to be able to see these compression fractures. If you have any questions, feel free to send me an email, or we will cover these in class.